I've mentioned a couple of times, please watch the crash course. The link is right here at the top. I'd really love for you to watch it before you do this PowerPoint, listen to the PowerPoint, and then listen to Hank again. There's just a lot of steps. There's a lot of sprinkling of cytokines everywhere and all of these things. And yeah. Okay, so the last time we started with the different adaptive defenses that we have. So the adaptive immune system is the third line of defense. So we started with the primary, which was your skin and your mucous membranes. And then we had several secondary. If you break the outer surface of your body, and so you have a breach of your skin or your mucous membranes, then we have a second line of defense. It's very non-specific. So some macrophages, some neutrophils, natural killer cells, inflammation, fever, those antimicrobial proteins that I talked about that were in the plasma, or they can come from other body cells. So like in plasma, we have lots of different kinds of complement that are going to go after bacteria, and then different body cells can release like interferon, interleukin. Don't memorize all those different kinds because there's a lot, and I'm pretty sure I remember seeing a chart in the book, which is not in your PowerPoint. I took it out. Okay, so then we moved on to the B lymphocytes, right? Talked about started with the initial, one branch of the adaptive is humoral. So when we talk about humoral, the humors are the liquids in our body. So blood, lymph, interstitial area is when we have a pathogen in those areas. So this is going to revolve around B lymphocytes. And B lymphocytes can't directly kill an antigen, but he can create antibodies that mark that antigen for destruction. So let me go back to the schooling from the lymph section, just to add on to that a little bit, because I keep saying they go to school and, you know, now they can do their job, but they can't, they have to actually be presented with their first challenge in order to create their armies. So lymphocytes, when they leave that primary organ, so B lymphocytes are going to leave the bone marrow, T lymphocytes are going to leave the thymus. They're called immunocompetent. And they're immunocompetent because they have these receptors on their body, okay, or on the cell. So these receptors are very specific, both for B cells and T cells. They're very specific. And let's say for the B cell, the receptor is an antibody, but that antibody stays on him. So that's a fixed antibody. When he is activated, so we leave immunocompetence, I've been to school, and I've met an antigen, I make an army, the B cells are going to, this army is now going to be called a bunch of plasma cells, and they actually release their antibodies, so these proteins floating around all in your body that are very specific to whoever his receptor was. So B cell that what came out of school, he might be great at getting, let's just come up with something. He was made to be activated by hepatitis, but this other B cell was activated maybe to get mononucleosis. Okay, I'm just throwing these things out there. Now, all these B cells have multiple receptors, so they can actually get multiple different things. But if they do not have a receptor for that antigen can just pass on by, and that B cell will not get activated, because that's not his job. He's got a bunch of other buddies that went to school with him to learn how to do somebody else. Very specific. Okay, so then let's do the B cells, but this is true for the T cells too. When they leave their school, they're going to go usually hang out in lymph nodes and they're going to usually meet their antigenic stimulation that lets them become active, so create armies. That's most of the time it's going to happen in the lymph node or the spleen. It can happen anywhere, but that's why the lymph nodes are considered the filterers of the lymph. We've got macrophages in there, dendritic cells in there. We've got the germinal centers full of B cells, and then the germinal centers are wrapped around the germinal centers in the cortex are some T cells, and then in the sinusoids, or the sinusoidal area, is going to be both B and T cells. So a lymph node is packed with different kinds of T cells in different locations. All right, what else was I going to say? This is the long slide. This is the 10-minute slide. So sorry. Just want to go through everything. Okay, so we had the B cells, and they made their things, and they're diverse. And oh yeah, antigen presenting cells. That was next. So we have different kinds of antigen presenting cells. There's only 3 actually that we know of. The dendritic cells, which they came from the epithelial areas. So your epithelium gets breached, right? Your mucous membranes and your skin, they get breached. Well, the dendritic cells that were hanging in there can grab a hold of that first little bacteria that just came in. Hey, you, grab a hold of it and break it up. And they're going to take a little piece of that antigen and stick it on their cell surface. Macrophages just live a little bit deeper. They're more in the connective tissue areas. And then B lymphocytes also are going to be antigen-presenting cells. And I'm going to get into them a little bit more. I mentioned it on the other PowerPoint, but explain it a little bit better in the T lymphocyte section, because the T lymphocyte section is who the B cell is going to be presenting things to. Okay, let's see. When that B cell he's been to school and now he is activated, and we'll get into how he's activated in more depth this time, but not much more depth. Now he can make his army. He's going to make a whole army of plasma cells that can make antibodies, but a few of his army are going to be memory cells. And those memory cells are not going to be putting out antibodies. They're on standby for the next time that antigen comes around, so that they can respond much faster. So the first time B cells meet an antigen, their response is a little slow. So but 10 to 14 days, your textbook says 10 days, is their peak response. And the second time that memory B cell meets the antigen, it's going to be within 24 hours. So much quicker. Okay, let's see. Antibodies, there was 5 different classes. That was the other thing. So antibodies have different classes. So I like gamed. Some people like MAG. It doesn't matter. So IgM, IgA, IgD, IgG, and IgE. So, and I guess that's all I'm going to say about that. Let me move on to this. Okay, we've told you about how the natural killer cells are constantly on patrol. They're part of innate. They kill any cell that's missing an MHC1. Every nucleated cell has an MHC1. But these antigen-presenting cells that I was talking about before, they have a special MHC protein, MHC2. Now they are nucleated, so they also have MHC1s. You know, your cell membranes are loaded with different proteins. You remember? So there was the integral proteins that were channels from AMP1, but there was also the peripheral proteins. So there's all kinds of proteins all embedded in a cell membrane. Okay, so these, let's do a macrophage. He has an MHC1 that says, I'm a macrophage and I belong to you. But then he also has an MHC2 that says, well, he's specific. he is going to take that piece of antigen that I keep talking about that he's going to put on his outside surface. As a presenter, he's going to take that piece of antigen and stick it on his MHC tube. That guy is going to be recognized by a helper T cell. So his little receptor is called CD4. A helper T cell is the CD4. You can't do anything in your body without helper T cells. He helps everyone. And I mentioned this in class the other day, or maybe in the last PowerPoint. Yep, 10.5 minutes. Okay. So here we go. Here's a review. We have these, all your nucleated cells has a class 1 MHC. Okay. Now today I'm going to tell you about how those MHC1s also can help present antigen, even if they're not an antigen presenting cell. The only thing is, if your nucleated cell is presenting an antigen on their MHC1, so if they're not an APC, if that's not their job, they're toast. And this is where we're going to come across, I mentioned that we have cytotoxic T cells that do the same thing, essentially, as the natural killer cells, but he is going to, here's where specificity comes in. He must recognize that MHC1, and he has to recognize the fact that that MHC1 has a specific antigen on him. If he is the wrong cell, then he could pass him by. He wants a specific receptor. They have to mesh up. Okay, now the antigen presenting cells, those guys are going to help out by getting the helper T's going. And again, we have to have the helper T's for everything. Okay, so some specifics about T cells, just what they can do and what they are. So T cells can defend us against bacteria. They can defend us against viruses. They can defend us against cancers. They can defend us about any abnormal cell. So there's precancerous conditions sometimes even that the body would attack, like actinic keratosis, so like precancerous skin lesions. If you have an organ transplant, that's not yours. So the reason that people take immune suppressant drugs when they've had an organ transplant for life is because we don't want those T cells to come and kill those guys. Most of the T cells that we have are helper T cells, because we can't do anything without a helper T cell. Helper T cells are going to be guys that are actually going to sprinkle everybody with their little chemicals called cytokines to help either enhance a performance or to activate somebody. They'll sprinkle them on macrophages to help a macrophage get going. Macrophages are funny. Macrophages even sprinkle themselves, and T cells can sprinkle themselves. So there's a lot of sprinkling going on. Okay. Okay, so T cell stimulation, T activation, I guess I should say, T cell activation. So what's going on with that is an antigen presenting cell is going to bring a little piece of antigen to a T cell. Most of the time this is going to be in a lymph node. I think I mentioned this earlier. Lymph node or spleen, but it can be anywhere. And on this slide, I probably shouldn't have written macrophage, because it could be a dendritic cell too. So dendritic cells came from the epithelial area. Macrophages come from the connective tissue area. Then we're going to end up with that activation. The T cells are going to form an army. They're called clone armies, and it's just going to be like B cells, except B cell clones are called plasma cells. T cells are not going to be called plasma cells, and they actually come in 4 different classes. The biggies are helper cells. 65 to 85% of the lymphocytes that you see in your smears, so like you do a blood smear, the majority of those are going to actually be helper Ts. Anyway, we have some regulatory guys, and we have the memory guys, just like with B cells. So let's go into some specifics about those different kinds of T cells. Helper T cells. There is a problem somewhere, somehow. There is a problem, and the helper T cells, now he has to get activated too. We'll get into details about that in a little bit, but he is going to, once he is activated, then his job is to help everybody else. He might help activate a B cell. He might help activate another T cell. He might actually sprinkle some cytokines on macrophages or dendrocytes and make them stronger. Now, yes, macrophages and dendritic cells can also, it's a two-way street. They might help the helper cells so that they can get activated too, the first time they meet their antigen. Okay, a few of those T cells are going to become regulatory T cells, and their job, because T cells can be so destructive, like let's say with your transplant, whatever, they can take something down. We have some regulatory T cells that whenever things start getting a little bit high of a response, the regulatory T cells actually release inhibitory cytokines that say, okay, that's enough. No more of that. You need to chill out. We've already been through the memory T cells. They're just going to help out the next time that antigen shows up. And then cytotoxic T cells are killers, okay? Just like the natural killer, but they're very specific. So they're going to go and kill a cell that has been invaded by a foreign antigen. Okay, so I have this slide. This slide is actually from the McKinley book. It's very pretty, I think. So we're showing on this one the way that we end up activating a cytotoxic T and a helper T. Okay, so on the cytotoxic T, so both of these guys have left the thymus, they've been to school, they've got their receptors, and they know what they're supposed to do. Well, notice on this picture, we have an antigen-presenting cell, and he has an MHC class 1. For the activating of CD8 cell, we're going to have the MHC1 from a dendritic cell do the job to activate this guy. So that dendritic cell is going to have an antigen on him. He's going to meet up with a cytotoxic T with his CD8 receptor. And as long as there's linkage, then that's half the battle. Okay, so we've got the right T lymphocyte, the right cytotoxic T with this dendritic cell and his MHC1 with his antigen. But we have to have another thing happen. We have to have a helper cell. And this helper cell has to be inactivated. Like he's already been through school. He's already learned how to do his job. He is roaming the streets, helping all the other immune cells. Because the second part of activating this naive, yet immunocompetent cytotoxic T cell is he has to be sprinkled with some cytokines. So in this picture, we've got some helper T cells sprinkling with interleukin. Then, once we've had linkage with the dendritics MHC1 and the antigen, and he has been sprinkled with some cytokines from the helper T, then he can make his army. Most of that army is going to be cytotoxic T cells, but some of them are going to be memory. Okay, activating the helper T cells. Okay, again, been to school. He is immunocompetent. He has all of his little receptors. He has CD4 receptors because he's a helper T cell. And now he is going to have one of those antigen-presenting cells. Just pick an antigen-presenting cell. It's either going to be the dendritic, or it could be macrophage, or it could be a B cell. But he is going to present him with his that antigen-presenting cell. So the macrophage or the dendritic cell is going to have his MHC2 and a piece of antigen, and we have linkage. Well, what about those cytokines? This is the crazy thing. That helper cell, who has the interleukins, he can sprinkle them on himself, and him sprinkling on himself makes him stronger and activated to make the army. He's even going to take some of them cytokines that he can release and sprinkle them on his army. There's a lot of sprinkling going on here. Okay, so this is showing kind of a summary of the whole thing of the acquired immune system, adaptive immune system. So the red bone marrow makes the formed elements in the blood, including lymphocytes. B cells mature in the bone marrow, but T cells mature in the thymus. Okay, so now they have been through their positive and negative selection. So in other words, they know to not kill your own cells. They've been to class to learn to not kill own cells, and they have learned how to kill the proper things. So they're officially immunocompetent, but they are naive. They go out into probably a lymph node. That's the best place to learn how to do your job, because the lymph node has all those afferents coming in and very few efferents, and the lymph node's job is to filter lymph. So we've got lots of macrophages in there and dendritic cells, so we have presenter cells, and of course then we have the germinal centers with the B cells. Anyway, it's a very crowded spot. Clearly no COVID going on in that. I shouldn't even say that. Okay, and so if it is a cytotoxic T, he has a CD8, and that's going to be his job. We're going to have a dendritic cell present a piece of antigen on his MHC1. That's how CD8s become cytotoxic Ts. If it is going to be a helper, it's going to have maybe a dendritic cell or a macrophage present a piece of antigen on its MHC2. So MHC1 for CD8, MHC2 for CD4, and then we're going to make a big old army, but some of them will be memory cells, and then they can float around in the blood plasma. They can go and hang out in a lymph node, though, or any of the lymphoid tissues. Okay. So this is actually talking about the summary of what I just said. You have to bind to the antigen, and then you have to have some sort of cytokine sprinkled on you in order to get stimulated. If you don't have both of those steps, you can't get activated. Helper Ts can sprinkle it on themselves, but they're going to go and sprinkle it on the cytotoxic too. So this is just saying that whole thing again. I did it on the picture, but here's the words if you want that. Anything else on this slide? Primary T cell response peaks within a week. So within a week, those guys are working really hard. So similar to the B cells, a little bit shorter. Okay, because T cells can be quite inflammatory, they don't live very long. So they're going to all be dead in less than 30 days, usually. Part of the regulatory T cells' job is also to make sure that they go ahead and don't overreact, but if they do keep reacting and they don't die, then you can actually even get a cancer if they don't get cleared. Now, a memory T cell, he's not active. He's just waiting out for the second time. So he's not going to hurt anything. Memory T cells can hang out for a while. Okay, this picture is actually very similar to the one that I showed you from McKinley. It's just this one is from your book, so I'm gonna keep going. All right, cytokines. So cytokines are just little chemical messengers that get sprinkled on everybody so that we can get activated. No, that's pretty generalized. There are some molecules that can influence the cells in lots of different ways. It can influence a cell's development, differentiation, but also here we're talking about the immune system, so responding to the immune system. So we've got some interferons and interleukins, and I think I already mentioned there's a chart in your book, and it was a slide, and I took it out because that's too much information, and I don't want you memorizing all that kind of stuff. But interferons are can be secreted by, well, it depends on which one, but they can be secreted by many different cells. Some of them are just made by lymphocytes. They can activate natural killer cells. They can activate macrophages. Just in general, they can enhance an immune response to the point that I would not be surprised if somebody is using interferon studies to help defeat this coronavirus. Kitties get leukemia virus, so it's called leukemia virus because it wipes out the white cell lines, not because it causes leukemia, the cancer. So back even in the 90s, we would have interferon, gamma interferon, and we would actually inject it straight into the peritoneal cavity of kitties with leukemia that were dying, that they weren't even making red blood cells anymore. And it was really quite amazing, but it was just temporary. So it'll get to a point where the body just doesn't respond anymore. But it would boost the lymphocyte count artificially, because you're giving this kitty this interferon, gamma interferon. And so that would help the body make lymphocytes and help that kitty feel so much better. But eventually, if you're not making white cells and you're getting infections, you can even get bone marrow cancer, all kinds of leukemia is terrible. But there's a vaccine for it. Anyway, interferons work great for viruses. Interleukin, there's several different kinds of interleukin, and interleukins can be released by macrophages or helper cells, mast cells, regulatory cells, dendritic cells. Anyway, there's all kinds of cells that can release interleukins. Now, depending on which interleukin it is, it depends on what it can do. And again, way too much information, and it's above the scope of this class. But just for example, some of the interleukins can activate the natural killer cells. Some of them are just completely inflammatory and can act as like a pyrogen to create a fever. Some of them are going to create the inflammation in autoimmune diseases, so that's not necessarily good, right? Anyway, you get the idea. There's all kinds, and there's even more cytokines that we're just not even going to get into. In general, they can help stimulate an immune response. All right, well, let's look at these guys. I have an activated helper T lymphocyte. His job is to sprinkle everybody. He's going to sprinkle B cells to activate a B cell. He's going to sprinkle himself. He's going to sprinkle other helper cells. He's going to sprinkle on a cytotoxic T cell. He's just busy sprinkling everywhere. Cytotoxic Ts are going to do something very similar to what the natural killer cells do, where they poke a hole in an infected cell and sprinkle it with some of their little granzymes, and that's going to cause apoptosis of that cell. So bye-bye cell. The difference is natural killers they're just noticing that a cell is missing an MHC1, and so they just poke it and kill it. They don't analyze the situation or anything. It's not necessarily because he figures out that something is invading that cell. He just recognizes that there is no MHC1, so he kills it. Very nonspecific. Okay, so helper cells, once they have been activated, they're going to go help everybody. So the B cells, I think there's a slide after this that I can show you how he activates the B cell. And remember, let's do the lymph node again. There's all these germinal centers full of B cells. What's surrounding the B cells, the germinal centers, is a bunch of T cells. So there's going to be helper cells in there galore. There's going to be cytotoxic T cells in there too. Those lymph nodes, or germinal centers in general, are going to have not just the B cells inside the germinal centers. There's going to be T cells closely associated around the periphery of that. Okay, so without a T helper cell, there is no immune response. He helps everybody. All of his little sprinkling is making sure that everybody is activated and ready to go, or even empowers that activated cell to do an even better job. Oh, good. Okay. So I told you earlier that B cells were antigen-presenting cells. So a B cell might gobble up something that's just brand new to him, like a hormone, and he might try and present it to one of these antigen-presenting cells, and the antigen-presenting cell, to a T helper, to a T helper, and that T helper is like, no, that's not an antigen. And so he doesn't sprinkle it. So he makes sure that that B cell doesn't attack things that he shouldn't be. Now, T cells do a better job of learning that kind of stuff in the thymus. But anyway, let's say that a B cell just came across, let's say you just got vaccinated. And so you've got an influenza virus that was an attenuated one, so a modified live. And he's got a little piece of that influenza virus on his receptor, which is an in-place antibody holder. He has to bring that little piece of the flu virus to a T helper, and then the T helper is going to sprinkle him with some of those cytokines, and then the B cell can make his little plasma cell army. Same idea, just a picture form. I love pictures. Same thing here. We have this T helper cell, and he is linking up with a dendritic cell presenting an antigen. And here we go. We've got this killer cell who is also linking up with him, and he's learning how to do his job. So what's going to end up happening is that T helper cell is going to sprinkle the soon-to-be cytotoxic T, because he has a CD8, so that he can go and do his job, so he can make armies. I know there's lots of repetition in pictures in here, but repetition's key to learning. How about that? I just think pictures are so helpful, and I do like McKinley's pictures a lot. So if you haven't figured it out yet, You must have T cells to activate everybody. Okay, so we've got this right here. We've got the B cell. He had his antigen, and he is meeting up with a helper cell, and the helper says yes. As a matter of fact, that is an antigen. We don't want him in our body, and he sprinkles him with some interleukins. Over here on the right, we have an antigen-presenting cell activating a cytotoxic T, and thanks to the helper T cell, he's going to sprinkle some cytokines on him, and he is ready to go. All right. How do T cells help with innate defenses? Well, you had those macrophages, remember? And they're constantly patrolling, and they're non-specific. But what can happen is a helper T cell can take some of those cytokines and sprinkle macrophages, and that makes them better killers. He also is going to, all the sprinkling that he's doing is going to help move lymphocytes and macrophages, whoever needs to help out in a specific region. Hey, I need you over here. I'm releasing these chemical messengers. This is a great spot to get some killing done. I need help over here, or whatever. He does that by releasing his little cytokines. Sprinkle, sprinkle. If we were in class, I have a game, and I give everybody a T cell that's a helper, or cytotoxic, or regulatory, and then I give some people some dendritic cells and some macrophages, and some people are pathogens, and then I give some people little packets of those pop rocks to be granzymes, and we have lots of fun running around and figuring out who's supposed to be attacking who and who's supposed to be helping who. So, alas, we can't do it, but it's quite chaotic, but fun. Okay, so I'm hoping you've got the idea now that the only true killer is the cytotoxic T cells and the natural killers. Natural killers are not specific. Cytotoxic Ts are specific. They're going to poke a hole in that cell that's very, very sick with something called a perforin and sprinkle the final little enzymes in there that's going to make that guy blow up from the inside out, called granzymes. So the cell, it doesn't matter because that cell was going to die anyway. It was either infected or it's become cancerous, and he's going to die anyhow. If you've heard of autoimmune disease, where the body gets confused and starts attacking itself, then you can recognize that the regulators have fallen down on the job. So we have these regulatory cells, regulatory T cells, that are supposed to keep the killer cytotoxic Ts and the helper cells from going crazy with all of their cytokine sprinkling. They should have just a lifespan, and then they'll be done. Less than 30 days, their T cells should be done. An organ transplant, again, is something that's not you. There's a lot of testing to make sure that you're matched as closely as possible. Of course, you have to have the same blood type, but it's more than that. Like this is pointing out, even MHC antigens can be similarly matched, won't be precise. Now, identical twins will have the same, of course, but they're going to do the best job to find the best match. However, they're going to have to stay on immunosuppressive drugs, okay? The problem with these immunosuppressive drugs is it's not just preventing their body from attacking their new organ, So it's not just preventing an autoimmune attack, it also makes these people more prone to other kinds of viral infections and bacterial infections that most of us, might make us sick, but not kill us. Now some organs, this textbook says that rejection is best circumstances that rejection happens around 10 years in half of the patients. I think that number is a little pessimistic. I don't believe that that is true. Okay, other kinds of immunodeficiency, so not being put on immune suppressive drugs or, just not being put on immunosuppressive drugs. This is going to be talking about sometimes you are born with certain immunodeficiencies, but more commonly, we have something that happens later on in life. So you weren't born that way, it happens later, so this is another use for the word acquired. Hodgkin's lymphoma is cancerous B cells. The good thing about this cancer is it is extremely treatable. Hodgkin's lymphoma is. Non-Hodgkin's lymphoma, you can't clump it like that. There's lots of different kinds of non-Hodgkin's lymphoma. So you can't say non-Hodgkin's lymphoma is mean or non-Hodgkin's lymphoma is not mean because there's too many different kinds. But true Hodgkin's lymphoma it's very, very treatable. It has a really good prognosis with treatment. Okay, then everybody's heard of HIV, human immunodeficiency virus. He destroys helper T's. Now, everything that you know with the helper T, because the helper T helps everybody, he sprinkles the B cells and activates the B cells. He sprinkles the cytotoxic T's that have met up with an dendritic cell to activate the cytotoxic T's. He sprinkles himself. He sprinkles macrophages to make them stronger. He sprinkles everybody to make them stronger. So if this virus is specifically going out and killing helper T cells, we may as well not have any, right? We may as well not even have any immune cells. So what would usually not bother a person, the simple little bacteria that is that we meet all the time and our body just fights it off, that could become a deadly infection for somebody with a true AIDS syndrome. So everybody that has HIV does not have the full-blown acquired immunodeficiency syndrome. And you've probably heard that before. And our drugs that we have for HIV really help with this. AIDS is when you are symptomatic from the HIV virus. Here's some examples of autoimmune disease. So this is when your immune system gets confused and starts attacking itself. So you've probably heard of rheumatoid arthritis. Well, your body's confused and destroying your own joints. Maybe you remember from AMP1, myasthenia gravis. What he's doing is he is destroying the receptors for acetylcholine. So if you remember this, the nerve releases acetylcholine. Acetylcholine goes and binds to the receptors on the motor end plate, and that is the ligand that opens up the gates that lets sodium in. Well, if you're lacking in those receptors, you have some. So your acetylcholine lets in some sodium, but those people are really weak. So there's actually acetylcholinesterase inhibitors that try and make sure that you get to use as much acetylcholine as possible. But that's an immune-mediated thing. The body has destroyed many of the receptors for the acetylcholine. Multiple sclerosis, we did that also in AMP1, so it destroys the myelin in the central nervous system. Graves' disease, so that causes hyperthyroidism. That is an autoimmune disease of the endocrine system. Type 1 diabetes, they think that maybe the immune system destroys those pancreatic cells, although they wonder if maybe it could have been triggered by a virus or something. Body got confused trying to destroy a virus, and then it ended up destroying some of those pancreatic cells that make insulin, the beta cells. Anyway, so those are just examples of different kinds of autoimmune diseases. And how do you treat that? Suppress the immune system. And just like with the, when you get a transplant, there's problems that can come along with that. So, they're always working on new kind of ways to help the immune system, new kind of ways to treat viruses and to protect people other than just relying on the immune system. But kind of like the central nervous system, it's complicated and we still probably have a long way to go. Well, you can see I made this slide a little bit smaller. This is not going to be on your test. But these are just other ways that you can have an autoimmune problem. So sometimes foreign antigens look kind of like something that's yourself, where your immune system makes antibodies against it, or has T cells will go after it. But then he comes across that cell of yours that has that self antigen that the foreign antigen looks similar to, and he gets confused and he says, "Hey, I thought I was killing you," and starts destroying yourself. So there's a disease called rheumatic fever, where antibodies are made towards a certain kind of strep bacteria, and it looks very similar to a heart antigen. And so he creates a response to this strep bacteria, but then he gets confused and he starts attacking what that strep looks like. So self antigens that are on the heart, and accidentally starts to damage the heart as well. Appearance of new self-antigens. So maybe you had some sort of gene mutation, or let's see that maybe you had some self-antigens that were tucked away, like say behind the blood-brain barrier, or the testicle has a blood testicular barrier. And these were antigens that have been hidden. And then you have some sort of trauma, and now these antigens are exposed. So now your body is going to say, I've never seen you before, I'm going to attack you. Okay, hypersensitivities. So what is this? This is when the immune system decides to attack your, it damages your own tissues when he perceives that something is wrong. So a pollen, something that you're allergic to, dust mites, whatever. So while it's busy trying to attack this thing that you're allergic to, ragweed, whatever, some of the tissues that you have get damaged in the process. So there's different types of hypersensitivities. And they vary based on how quick they happen or how long they last. So based on their time. And then is it a B cell sensitivity? Is it a T cell sensitivity? Usually B cell sensitivities are going to be immediate, so really quick. And then T cells are usually going to be a little bit delayed. Okay, so let's go through the immediate hypersensitivity. So when you have an allergic reaction to an antigen, it's going to be called an allergen, and you probably could figure that out, right? The pollen count is high, the allergens are high today. And it can be instant, depending on how, if you've ever been around somebody that's allergic to cats, and they enter a cat home, that is quite stinking fast. They should have just taken the Benadryl before they ever walked into the house. This would be an acute or type 1 hypersensitivity. I mentioned with the antibody section, IgE is the guy that's going to be seen with allergies, and he is going to help activate the mast cells and basophils that's causing the release of histamine. If it's not just hanging out, if it's bad enough, which the way that it usually gets really bad is repetitive exposure to that problem. So the first time you met it, it was already a pretty significant problem, you know, like peanuts or bees. And if it gets bad enough that your whole body starts with a response, that's going to be termed as anaphylactic shock. So you're going into circulatory collapse. Your bronchioles are going to constrict. You're going to end up with your vessels start to get really wide. What's that going to do? It's going to slow down blood flow. So in a nutshell, you're going to collapse. It's treatable, epinephrine. People that know they're allergic to bees or people that know that they're allergic to peanuts often will have EpiPens. Probably too much information on this slide, but we can go through it. You have this antigen, and then here's your plasma cells that make the antibodies. The mast cells are going to grab a hold of that specific antibody as IgE, and he's going to release his histamine. When he releases his histamine, that's going to affect your blood vessels. They're going to dilate. You're going to start making lots of drippy from your nose, maybe your eyes. And if it's bad enough, your bronchioles will constrict. Okay, cytotoxic reactions are still going to be antibody-based, so still has to do with the plasma cells. But the antibodies that are being released are going to be IgG and IgM instead of IgE. It's a little bit slower, 1 to 3 hours, might last longer, 10 to 15 minutes. Of course, you know, anaphylaxis, you've got to go to the doctor really quick or else you're going to die because you can't breathe or have that EpiPen. Let's see, what else do I want to say about this? So those antibodies are going to bind to an antigen, and it's going to end up stimulating the immune system for the macrophages to come and start doing some gobbling. You might end up activating complement on this one. But what's going to end up happening is going to start to kill things. And the common one on this one is red blood cells. I probably should make this slide a little bit smaller too, because I don't foresee me doing a test question on that one. Okay, a delayed hypersensitivity. Everybody's probably at least met. If you haven't been through something like this, you know someone that has. So delayed hypersensitivities, these are caused by T cells. So it takes like a few days for this to happen usually. You met the antigen, but you don't really know that you met that antigen right away. So the way that we used to do TB testing, it's a little prong that goes into your upper arm and they check for a reaction, but they have you come back days later to see if you had a reaction. So it's kind of slow. Poison ivy. When you rub on the poison ivy, you don't break out right away. Now, it depends on how allergic you are to it. If it's the first time you've ever been exposed to poison ivy, it might be 3 days. But if you're one of those people that's been exposed over and over and over, then you might react in a day or less. Can't really think of anything else on that one. Okay, so I mentioned this a lot in AMP1. As we get older, things just don't work like it used to, and that includes the production of functioning T cells. So, they have a life. B cells are a little bit longer lived, especially those plasma cells. But T cells, we don't want them living around forever. And remember, our thymus did get smaller. So just as we get older, we're just not as strong in our immune system as we used to be. And then sometimes things just go rogue. So you might be more prone to cancer because you don't have that as good of a surveillance anymore, like those cytotoxic T cells. And even natural killer cells, they're created. They're a weird type of lymphocyte that's being made by the bone marrow. So we don't make things as well as we used to, and so our immune system starts to get poopy, just like everything else as we get older.